Hello everyone, this is Vanessa Chaffone today. I'm going to be demonstrating how to perform a primary, secondary trauma survey as well as an EFAST exam. The trauma survey is always done in a systematic fashion with the ABCDE method so that it's always the same and that you won't miss any injuries or anything that could be life-threatening after a trauma. So the first thing we're going to assess is A for airway. So a good way to initially assess your airway is to see if your patient is talking, because if they can talk, then they obviously have a good patent airway. So sir, can you tell me what's your name?
Andres.
Hello, Andres. Sorry you're in this position. So he obviously has a good airway. If your patient is not talking, of course, you're going to have to see why. If they are unconscious and have a GCS of an 8 or less, you want to go ahead and intubate. If your patient is alert but can't phonate and can't form words or no sounds can come out, then you want to assume an airway injury and go ahead and establish an emergent airway. Then you're also going to be assessing any face or neck injuries because those obviously can compromise your airway as well. You'll be looking for swelling in the neck and also hematomas because those can cause compression to your airway. Bleeding from facial or nasal fractures can also put the patient at risk for aspiration, and then feeling for crepitus around the neck region is also important because that can be indicative of a laryngeal or tracheal injury. So my patient has a mask on for obvious reasons, but we're going to assume he doesn't have any bleeding coming from his nose. I do not feel any crepitus around his neck or upper chest, and I do not see any swelling or any hematomas around his neck either. Of course, if I had another person with me, we would be holding C-spine because making sure we're protecting our C-spine and keeping that stable until we have a C-collar on the patient is very important because a high C-spine injury of C5 or higher will obviously impair our respiratory drive. We also want to make sure we're assessing for any burns, particularly around the face, neck, or chest area because thermal injuries can also cause swelling of the airway, and inhalation injuries can also cause hypoxia. So if you know your patient is coming in with where there could be burns, you want to be making sure you're being mindful of that. Airway management, like I said, we always want to make sure we're intubating as soon as possible if we think that there is airway compromise or that it might be imminent. We want to maintain our C-spine immobilization and always remember that if you can't establish an airway with intubation, that surgical airway intervention may be required for any severe neck or facial injuries. So after making sure that we have our good patent airway with this patient, which we do, we're going to then assess our breathing. So of course, the first thing we're going to do is we're going to listen with our stethoscope to make sure we have equal breath sounds on both sides and that we hear breath sounds on both sides. Then we're going to be looking at our patient, keeping note of their respiratory effort, and of course any chest injuries, which my patient here, he's breathing very equally, chest rise and fall is good, he doesn't seem to be in any distress. And then of course we're going to count our respiration as well because we are going to be most concerned for a patient who has very significant tachypnea because they can easily tire out, and then we're going to need to make sure we're establishing an airway. And then of course we would monitor an O2 sat probe to make sure that our lungs are functioning in the way that they're supposed to. We want to be making sure we're assessing for any pulmonary life threats would be like a tension pneumo, an open pneumothorax, flail chest, and then of course massive hemothorax. We want to establish O2 as soon as possible if the patient is needing it. We want to titrate our O2 to an SpO2 of 95% or more, and typically we're going to use a non-rebreather. And then of course we should get a chest x-ray, but only once our patient is stabilized to make sure that we don't have any injuries. After our B for breathing, which our patient's breathing is great, we are going to establish assess for our circulation. So first thing we're going to do, of course, is look at our patient, make sure that their color is good. My patient is pink, looks great. He has a good level of consciousness, which we already assessed. We're going to look at our cap refill. We want to make sure we're assessing cap refill on both sides, and our cap refill is less than 2 seconds. And then, of course, look for any signs of external bleeding, which our patient does not have. Next, we're going to feel, and we should be making sure we're feeling for our peripheral pulse strengths, because those pulses are indicative of what our blood pressure is if we don't know what our blood pressure is yet. You actually want to start more for your distal pulses, because like for example, your dorsalis pedis would indicate a systolic blood pressure of at least 90, whereas a carotid is going to indicate a systolic blood pressure of at least 60. So if you feel good distal pulses, good radials, which would indicate a systolic blood pressure of at least 80, or dorsalis pedis pulses, you know you have a good adequate pulse on your patient. And then of course we're going to have our patient hooked up to the monitor to make sure we're continuously monitoring our pulse and our blood pressure. Our circulatory life threats, of course, are going to be major hemorrhagic shock, so looking for any sources of bleeding and controlling that bleeding. Our patient does not have any bleeding. Looking for any tension pneumos or cardiac tamponades, because those can also compromise our circulation as well. Then, like I said, we're going to control our hemorrhage with direct pressure for our patients if there is any areas of massive hemorrhaging. Very important that we establish large bore peripheral access. So in this patient, he came in with a 16 gauge in his AC from EMS, so it's important that we establish another line in him so that we can, if we need to fluid resuscitate him or start any blood products, we can do so. If IV access, peripheral IV access is not able to be adequate, it's definitely reasonable to start an IO on the patient, or to place a dedicated trauma line such as a femoral cordis to make sure that we have good adequate access for this patient. So we have a 16 gauge on this side. I have another nurse that just started a nice 18 on that side. You can also draw your labs at that point. And if we're needing to initiate any IV fluids, we would start with isotonic crystalloid, like normal saline or LR. And we're only going to move on to blood transfusion for like massive blood transfusion protocol if our patient we know has a large hemorrhage, or if they are not responding to IV fluid resuscitation. So next we're going to move on to D, which is assessing our disability of our patient. So of course we've already established looking at our level of consciousness. You can also look at your AVPU score, meaning if your patient is if they are alert, if they're only able to be responsive to verbal stimulation, pain, or if they are unresponsive. We've already established that Andres here is awake and alert, so we are good with that. Then we would also assess our pupils, making sure that they are equal and reactive, which we are. Of course, you would use a pen light. I don't have one with me, but you would use a pen light. And then if your patient is altered, it's very important that you check a blood glucose level, because hypoglycemia could make your patient altered, but also could be what maybe caused your patient to have a trauma. Maybe they were hypoglycemic and got into a car accident. You're always going to make sure you're assessing any neurological life threats, such as a penetrating cranial injury, which our patient does not have, because you want to be thinking about any intracranial hemorrhages as well. Now, when your patient does have a disability in their level of consciousness, like I mentioned before, we're going to intubate for GCS less than 8. We're going to make sure we're giving supportive care and supporting their oxygenation and perfusion with the measures we talked about in breathing and circulation, and making sure we get emergent cranial imaging, which most important is going to be a non-contrast head CT. Then after we assess our D for disability, we're going to go to E for exposure and our environment. Typically in most traumas that I've been a part of, this kind of happens all simultaneously, but most of the time when they first get on here, we're already going to expose the patient. We're going to cut off all their clothes. They're never happy about it, but we're going to cut off all their clothes. We want to make sure we thoroughly assess their entire body, especially the areas that are kind of hidden, like their axilla, in the genital regions. All those areas are good places that injuries can be hidden, and also the back of the head and neck, especially once you get a C-collar on your patient, you want to make sure you're still looking at the back of their head and neck to make sure that there's no injuries. Then at this point, after we've kind of done our primary trauma survey, my patient is looking pretty good. He was in an accident, but he doesn't really have any outward injuries. We're going to, of course, always do our E-FAST exam via ultrasound. So I don't have the real ultrasound, and I'm certainly not going to make my coworker take his shirt off. So The first point of view, you're going to use the curved probe, and the first point of view that you're going to look at is your patient's subxiphoid view. You're going to have the indicator towards the patient's heart, or head, excuse me, and you're going to really press in here, and you're going to kind of get up and under, and you're going to be looking through the liver to the heart, and you're going to, of course, be looking for the presence of cardiac activity. That's obviously important. And you're going to be looking for the presence or absence of any pericardial fluid, particularly along the right heart border. So you're going to be up in here, and you're really going to kind of press and kind of swivel and look around, make sure that the heart looks okay. Then you're going to go to a right IVC view, which is to the right of the midline of the upper part of the abdomen. And that's going to, your indicator is still going to be towards your patient. That's going to be looking at the patient's liver, their diaphragm, of course their IVC, and then the right side of the heart as well. Then we're going to move to a right upper quadrant area here, keeping your indicator towards the patient's head in the coronal plane. We're going to go over here too, and you're going to look kind of like a more anterior and then a posterior view, kind of sweeping all along here. And what you're looking at here is you're looking at the liver, you're going to be looking at the kidney, and then particularly Morison's pouch, which is in between your liver and kidney. That's a very common place for fluid to accumulate. And then, of course, your diaphragm, you're going to be looking for fluid above the diaphragm, which would indicate a pleural effusion or a hemothorax. You're going to also make sure you're keeping note of your spinous stripes, and you can also get a view of the lung at this on this view as well to look at any pneumos or hemothorax. Then you're going to move over to the left side. I'm sorry, unfortunately, can't see that great on this side, but kind of going to be as similar as your right side of your patient. Indicator still going towards the head, and you're going to be more focused on this side, looking at the spleen, because fluid is more likely to be above the spleen, but then below the diaphragm on this side. And then, of course, looking at the left kidney. Then we're going to take a look at the pelvis. We're going to do a sagittal view, so keeping your indicator towards the patient's head. And what you're going to be looking at here is, of course, seeing the bladder and then any fluid around the bladder. And then you're going to do a transverse view this way, looking at the with your indicator towards the right side, and then looking at the bladder as well, seeing if there's any fluid around the bladder. Then you're on a last part you're going to look is you're going to do sagittal views at the second intercostals, kind of mid-clavicular on both the left and right side. And this is looking at the presence of pneumothorax on both the left and right chest. What you're going to be looking for is sliding of the pleura. That is actually normal. You want to see sliding. If you do not see sliding, then that's going to indicate pneumothorax. The big thing you're going to look at is that sharp corners that are between any of your structures are going to indicate fluid between the anatomical structures, because the structures themselves are more rounded. So if you see fluid within them, that's okay. If you see fluids with the sharp angles in between the structures, then that is something that you want to be worried about. And then typically what you'll say is that your FAST is either positive or negative for findings, and then that will indicate either how much fluid you see or where you see. Your mechanism is going to determine if we're going straight to the OR or if we have time to go to CT to look at the abdomen. Now, after all this is done, my patient's FAST was negative. He doesn't have any injuries. After we've then, of course, gotten whatever other necessary imaging we needed, chest x-ray, CT if necessary, then we're going to move on to our secondary survey, where we're going to do a more thorough history and head-to-toe assessment on this patient. So I'm going to ask him about, what exactly happened to you and your injury today. Were you in a car accident?
Car accident.
You were in a car accident. Were you wearing your seatbelt?
Yes.
Very good. Awesome. So do you have any significant medical history?
No.
No? Healthy guy. Do you smoke?
No.
Do you drink?
Yes.
Okay. Do you just occasionally social drink?
Yes.
Great. Okay. Are you allergic to any medications?
No.
No. Okay. Great. And we're going to do a very, very thorough head to toe. We're going to really be feeling all around the head, checking for any scrapes, bruises, bumps, all that. Back of the head as well, back of the neck, and everything looks good with him. I do not see any injuries. Then we're also going to look at the chest. Of course, he would be undressed, so we would be able to see any penetrating injuries, any scrapes, cuts, bruises, swelling. Everything looks good here. Move on to the abdomen, and we're really going to make sure we're palpating here. We're going to use our tips of our fingertips, and we're really going to press and palpate any pain in any of these areas. Great, and we want to go systematically from right upper quadrant and around. Then we would, while still keeping C-spine intact and really doing a total spine, we want to also initiate use a log roll to roll our patients. We're going to also roll the patient, and we're going to feel down the patient's back. So I don't have anybody to log roll, but he's going to roll over to his side for me. There you go. And we're just going to press down, and I want him to tell me if he feels any pain anywhere I'm touching.
No pain.
No pain, no pain, no pain,
No
no
pain.
pain, no pain.
No pain.
And then in these patients, if they're awake and alert, we'll ask them, squeeze your butt cheeks together. They can squeeze their butt cheeks together, good. On our non-awake patients, sometimes you'll have to do a rectal exam at this point to make sure if there's any spinal cord injury. With that also, when we're going to assess the genital regions, because we're going to look if there's any wetness, maybe the patient was incontinent, and particularly in male patients, we're going to look at if there's priapism. That would be an indication of a spinal cord injury. We're going to check the upper extremities, really looking, of course, making sure we're looking in the axilla, checking for any type of injuries, any pain, no cuts, no bruises. Doesn't feel like any deformities are here. We're going to look here as well. No deformities. He seems to be moving everything well. And then doing the same thing with the lowers. Particularly also, too, we're going to move, check the hips, make sure everything seems to be working well here. That is pretty much the trauma survey. Thanks so much.